Welcome everyone to the webinar Thriving in Substance Use Disorders, Service Delivery During the Post-COVID Era. My name is Andrea and I will be helping this facilitation, this session today. Thank you to all of you for being here. And as you know, this is the second part of our webinar. This is a 6-part webinar. And we are having today Dr. Jason Bolin. Dr. Bolin is a professor of medicine in the Division of Infectious Diseases at UT Health San Antonio. He is the chief hospital epidemiologist at University Health and the medical director of infection prevention at UT Health San Antonio, among other things. And his areas of expertise include infection prevention, antimicrobial stewardship, and emergent infections. Thank you so much for being with us today, Dr. Bolin. It's a pleasure to have you in our webinar. Before we start, I want to remind all participants that this session is being recorded and will be available later at our Be Well Texas YouTube page. If you have questions during the presentation, please feel free to add your questions to the Q&A box, and Dr. Bolin will address those questions or comments at the end of this class. So again, thank you. And Dr. Bolin, welcome again to the webinar. Whenever you're ready, you can introduce yourself briefly, and if we could start with the presentation.
Thank you. I appreciate the opportunity to be here today to talk with you all. We'll be talking about COVID-19, RSV, and flu. It's that time of year again. And I think it's really important that we talk about how we can be better informed so we can be preparing our patients and clients for the respiratory virus season that's really already upon us. I think one of the important, let me move here, there we go. Here's the disclosures, no financial disclosures or conflicts of interest. Here are our learning objectives today. So we're going to review the epidemiology of COVID-19, RSV, and influenza, including the impact on patients with substance use disorder and other risk factors for severe disease. We'll talk about the available vaccines and, importantly, the current recommendations. As you know, they update these recommendations annually, so we'll talk about the most up-to-date recommendations, the benefits and risks. And then we'll also talk about antivirals. And I think this is something that doesn't get as much press as the vaccines, but they're also important to know about and how to best utilize them. And so we'll first start talking about epidemiology, right? So I put this picture of a weatherman here, a meteorologist, because really every respiratory virus season, I get this question all the time. What's COVID going to look like this year? What does flu look like this year? And in a way, we're trying to predict the future, right? Every respiratory virus season is a little bit different. We all are unfortunately very, very familiar with COVID and seeing the kind of peaks and valleys with COVID activity. But I think it's important that we stay aware of what's going on. One of the things that I think is happening in the US is that we've gotten a little relaxed. We just think that COVID, flu, and RSV are something that just happen. And it's true, they do happen in the fall and winter, but there are still important things that we need to be doing to keep ourselves protected and protecting other vulnerable members of our community. Just for context, for numbers, for the 2023 flu and COVID-19 season, over 400,000 people were hospitalized in the US with flu, and about 900,000 people were hospitalized with COVID-19. So we're still seeing large numbers of people with severe disease. So it's important to know when activity starts to increase so that we're taking the right measures to protect ourselves. So I want to show you some data, some information that you can use so that you can be aware of what's going on with COVID. There's less information now reported to the CDC on the COVID data tracker because at the end of the public health emergency, there's less mandatory reporting. But there's still some good information here. If you want to see what's going on with COVID-19 activity in the US, you can see these early indicators with test positivity and ER visits. Those tend to go up before we start seeing more and more people get sick. And then the ones on the right, the severity indicators, the hospitalizations and deaths, we tend to see those go up later on after activity has already increased some. So that information is still available on the CDC website. You can also look at flu, and there's a nice map view of the flu that I like that shows the activity by color coding. And so you can see that right now we're in low flu activity for Texas, but we're starting to see increasing flu activity, and that will continue to increase over the next couple of months. But this is a helpful way to look at where flu activity is. It's also helpful for people that plan to travel. There's going to be a lot of travel at the end of this month for holiday season, so people can look ahead to where they might be going. So I find this is a helpful website to have bookmarked as well when you're checking on flu virus. An interesting website that the CDC has developed that I think is really nice if you just want to have one website, not look at COVID-19 and flu separately, is they've developed this respiratory illnesses data channel. And you can look at overall respiratory illness activity in the United States, and you can see here it's low, although I think that's just been bumped up to moderate since I last updated these slides a few days ago. You can also look at a specific state, so that's helpful. And then it has some other information. It has wastewater activity and emergency department visits in the United States. And so it breaks it down by the big three that we're talking about today, COVID-19, flu, and RSV. And you can see that RSV is already at moderate and is increasing. Flu is low and increasing. COVID-19 right now is minimal, and it's decreasing, but we anticipate that that will increase later on this winter. So we will see more increase there. And this respiratory data channel is one of the ways that the CDC is trying to consolidate the respiratory viruses and try to make things easier for people to be able to track activity. Another more local, a statewide resource that I also think is helpful is through Department of State Health Services. You can sign up for email updates, and they will email you a respiratory data report. So you get that once a week with activity in Texas. And then that's that bottom left red box that you see there. And then there's also a respiratory illness interactive dashboard that I have highlighted with a red box as well. And I'll show you a screenshot of what that looks like if you click on it. You can look at weekly emergency department visits by age group, which is really helpful. So you can see this is tracking from January to current, ending last week. You can see that RSV and influenza are present. COVID-19 really is not really that visible, but we're starting to see an increase in RSV and flu activity. So our statewide activity is mirroring what we're seeing nationally. So again, this is another data feed I think is helpful. And getting the weekly emails, I know we all get a lot of emails, but this is a way that you can be reminded to maybe check your websites to see where respiratory virus activity is at in the state of Texas. So who is at higher risk for severe disease? This is an important question. We want everybody to take precautions to protect themselves, but especially our most vulnerable members of the community need to take precautions to protect themselves during respiratory viruses. So young, healthy people may just have a few sniffles, may not be that sick, but other people that are more vulnerable can end up having to see a doctor, or even worse, go to the ER, end up in the hospital, worst case in the ICU, or even die from these respiratory virus infections. And so it's important to recognize who's at higher risk for severe disease. This is an infographic from the CDC, and really what you're seeing is that this list of who's at higher risk is pretty comprehensive. It's a pretty big list of people. When we're talking about seeing the people that we see in the clinic for follow-up, for medical care, it's really the majority of the patients that we're seeing. So we know that people at the extremes of age, very young, children less than 5, and especially less than 2 years of age, or adults that are 65 years of age and older are at higher risk. And this is specifically looking at influenza-related complications. There are some pediatric patients that take daily aspirin for Rye syndrome, or take daily aspirin and are at risk for developing Rye syndrome if they get flu, so they're at higher risk. Obese patients, particularly with a BMI of 40 or higher, are at higher risk of respiratory failure and severe complications with flu. Immunocompromised patients, for obvious reasons, they don't have the immune system to help them to get through the infection. Our pregnant patients are at higher risk. And our postpartum patients in that immediate 2-week period after delivery are at higher risk for respiratory failure. Patients that have chronic medical conditions, and you can see those 2 boxes on the bottom really cover most of the major organ systems of the body. They are at higher risk. American Indians, Alaskan Natives are at higher risk. And then our long-term care residents, they're at higher risk for a couple of reasons. One, they live in a congregate care setting, and so they have more exposure risk. But they also tend to have more chronic medical conditions and tend to be older. Many of them are 65 and older. So they actually have numerous risk factors for more severe disease. And that's also why an outbreak of respiratory illness in one of those long-term care centers can be such a big problem. Now, when we look at the risk factors for severe COVID-19 disease, there's a lot of overlap, which makes sense, right? If you're immunosuppressed, you're going to be at high risk for both. And so here's a little Venn diagram that shows the overlap. And most of the conditions that put you at higher risk for influenza put you at higher risk for COVID-19. The younger age seems to shift a little bit more towards influenza, and Rye syndrome is more of an issue with pediatric patients. COVID-19 has some additional risk factors. You can see substance use disorder, and we're going to talk more about that. A smoking history, hypertension, Down syndrome, Living in rural communities is considered a higher risk because it's harder for people in rural communities to access healthcare. And then people that are experiencing homelessness are also at higher risk for the same reason. They may also have some chronic medical conditions, but they tend to have more difficulty accessing healthcare earlier in a timely fashion to reduce some of the severity of their illness. So when we look specifically at substance use disorder, and influenza and COVID-19 outcomes, I think it's really important to recognize that the literature is really limited. As you all are probably very aware, we need more information and data so that we can better understand how illnesses affect this vulnerable population so that we can better support them and remove some of the barriers. Most of the available studies in respiratory infections in this group, in this population, are generally look-backs. They're retrospective cohort studies or case control studies. So kind of lower level studies in the tiers of performing trials. There is enough data to suggest higher risk for COVID-19 that it's listed as a risk factor by CDC, but I think it's important to recognize that many of the presumed associated factors with substance use disorder that increase the risk for severe COVID-19 really apply to other respiratory infections as well. We just don't have as much data. So in my mind, I really consider patients with substance use disorder to be at higher risk, not only for COVID-19, but for other respiratory infections like influenza and RSV as well. I did pull a study that looked specifically at influenza, drug use and severe outcomes amongst adults that were hospitalized with influenza, and they looked over 2016 to 2019. They used data from the Influenza Hospitalization Surveillance Network. So they had a huge number of cases because of this database that they were using. And out of over 48,000 eligible flu cases, a little over 2,000 were people who used drugs. And when they looked at that, they saw they had a greater odds of ICU admission and mechanical ventilation. However, when they started to do some risk adjustment, they saw it wasn't statistically significant. But further, what they saw was that opioid use seemed to be a specific driver of those odds. And what that tells me really is that we still need to do some work on better understanding how we study people with substance use disorder, that there can be some differences, right? It makes sense using different substances, but more importantly, I think there's going to be some differences for the duration of time someone's been using substances, what their age is, and when you're studying them. So there's other factors that weigh into this that I think don't get accounted for too well, even with risk adjustment in retrospective studies. The conclusion of the authors was that targeted initiatives to prevent flu in this population remains important to prevent severe outcomes. And in this table 5 in this box below, what you see is that opioid use seemed to be more of a driver for ICU admission and mechanical ventilation than stimulant use. But again, I would say that this just shows that there's some weaknesses with this study overall, and that we need to look at better ways to evaluate this vulnerable population so we're doing better in protecting them. This was a different example study that I pulled that looked at substance use on severe outcomes with COVID-19 infection. And it really was a literature review that included 12 articles, and it was a mix, but again, they were retrospective case control studies, observational studies, matched cohort studies. And importantly, what they saw was that if you have a patient or a client that's diagnosed with any substance use disorder, they are at higher risk of exposure to and developing COVID-19. And this is thought to be due to the socioeconomic barriers and inequities in social determinants of health that most of them experience. So not only are they at higher risk of being exposed and developing COVID-19, but they were also at higher risk of severe outcomes with COVID-19 infection too. So it's kind of a double whammy. And I think, importantly, this increased risk was believed to be due to the pre-existing conditions that complicate the disease process. So maybe not the substance use disorder itself, that might be contributing some, but some is more just these pre-existing conditions. And I think the last bullet in this key points on the right is the most important, in that the increased risk of infection are not specific to SARS-CoV-2 and COVID-19. So it really indicates that this population is going to be more vulnerable also to other infectious diseases. And so I think this definitely would also apply to influenza and RSV. To sum up, I've kind of repeated this. I think that patients with substance use disorder are really at severe risk of severe outcomes with COVID-19, but also influenza, RSV, and other respiratory viruses and other infectious diseases. But for the purposes of this discussion, it's important that we're taking measures so that they're informed and aware of what they can do to help reduce some of their risk of getting infected or blunt the severity of illness. So I think it's important that we stay informed about respiratory viruses because it really helps adjust our pretest probability if you're trying to diagnose what a patient may have. With upper respiratory infection, it's helpful to know if respiratory viruses are circulating, if there's high level activity. It also helps you to know when you start informing your patients or clients that they're at high risk for complications, and that they need to know that when activity is higher, they should think about taking additional measures to protect themselves. And so that could include wearing a mask if they're going to crowded indoor settings, staying away from sick people. Some of these measures are probably good to do all the time, but are especially important when you're starting to see increased respiratory virus activity. Substance use disorder does appear to be associated with more severe outcomes of COVID-19, and likely other respiratory infections. You can subscribe to information so that you get updates on respiratory virus activity. So the Texas Respiratory Virus Surveillance Report, I showed you that you can sign up for email updates for that. CDC also has health advisory notices, and you can bookmark these other reference websites I've mentioned. I highlight some of my favorites. There's some other ones out there as well. Very important to emphasize prevention measures with high-risk patients. Not only so how they can prevent getting ill, and we're going to talk about vaccines, but also what to do when they get sick, and we'll talk about antivirals as well. Before we talk about those, however, I'd like to talk about diagnostics. And I think this is a question, I don't know if you've received, but I've received multiple times. Should I use at-home tests? How good are at-home tests? How to use at-home tests is a question I think we should probably be asking quite a bit as well. So when we look at the types of diagnostic tests, there's really two major categories that we're talking about. There's the nucleic acid amplification tests, and the most common example of this is PCR testing. And then the other big category are the antigen detection tests, which are really the at-home tests that people use. And there's pros and cons to both. So the pros for the PCR test, these nucleic acid amplification tests, or NATs, is they have really high sensitivity and really high specificity, which is helpful. They can also test for more than one pathogen. There's a 3-pathogen panel that's used in a lot of outpatient clinics or urgent care clinics that has influenza, COVID, and RSV. For our patients that are being admitted to the hospital where I work, there is a panel that has over 20 pathogens on it. And it's helpful because you can look at several different things at once. The con is that these are expensive. They often take longer to get the results back. And you can have persistent positives as well, right? So you can have a positive test in somebody that may have had COVID a couple months ago because they're so sensitive and they're amplifying the RNA of the virus. So it's important to recognize that the patient has symptoms or not before you do testing, because this persistent positive could be a potential issue. In the other category, for the antigen detection tests, which are what people are using at home, and in some clinics have these as point-of-care tests. The pros are that they're generally fast. You get the results usually within 15 minutes. They're generally cheaper. You don't have to have a specialized lab to run it. They have high specificity, which is good. That means if you have high virus activity and you have a positive test, it's likely a true positive. The con is it has lower sensitivity. And so that really runs the biggest Achilles heel or biggest vulnerability with these at-home tests. With the lower sensitivity, if you have high virus activity and somebody with symptoms, you can still get a negative test. You can get false negatives with these antigen tests, these at-home tests. And it's important for people to recognize that. The other thing is that people may not use them correctly at home. They may not read the instructions. People may not do it correctly. If you don't do it correctly, it's even higher likelihood that you're not going to get good results. So those are important things to note. Here is some published data on false negative influenza antigen results. So the RIDT stands for Rapid Influenza Diagnostic Test, but those are antigen tests. And what this study looked at, this is from Annals of Internal Medicine, they compared the pooled sensitivity and pooled specificity for both flu A and flu B strains. And they looked at how the NATs or the PCR test compared to the antigen test. And what you can see in that red box there is that the sensitivity is only a little over 50% for both flu A and flu B for the antigen or at tests, which is not much better than a coin flip, versus the PCR test where it's over 90%. So you can see that the rapid NATs have sensitivity and specificity over 90%. So they are more sensitive and specific. And so that's a real challenge. You can run into false negatives. The big problem you worry about with a false negative test is you don't diagnose somebody. If you have somebody that's at high risk for severe outcomes, they may not get antivirals, which could help blunt the severity of their illness. And so it's important that people that are at high risk for severe outcomes know that if they continue to have symptoms, they may need to get a follow-up test. An antigen at-home test may not be sufficient. If they have severe symptoms or persistent symptoms, they probably need to be seen by a healthcare provider that can get them set up with a nucleic acid amplification test. So we talked about antigen testing for flu. COVID-19 testing has similar challenges. Again, you have your NATs, your PCR tests. and the antigen test. Most people are familiar with these. A lot of people have these stockpiled at their home, and it's the same issue. The at-home tests are easier to use, but you have the risk, the specificity tends to be pretty good, but the sensitivity is lower, and you can have a false negative test. And so that's one important part. The other important part is that people read the instructions. For a negative, most of those tests suggest that you repeat the test, usually in 24, 48 hours. The other thing that you need to check is to make sure that your patient or client has not just stockpiled and is using an old test. And I'm going to full disclosure, acknowledge that I used an old test when my son was sick, and then I realized that the expiration date had been passed. The FDA did extend the expiration date for a lot of these tests. And if you go to the FDA website, you can click on the type of test you have and enter the lot number, and it will tell you what the extended expiration date is. I did that, and I found even my extended expiration date had passed, and so I just had to throw out the tests. So it's important for people to use a valid test. These tests have liquid in them and also some proteins, and that liquid can evaporate over time. And the proteins that are used to detect the antigen and the virus can actually degrade over time as well. That's why there's a shelf life. So they do go bad. And if they go bad, basically what will happen is you'll get a negative assay, even if someone is definitely positive for infection. Now, in good news, there are some more tests available, at least 4 tests per household. So people can go to covidtest.gov, and this is probably a good time to do it before COVID picks back up again and people get interested in this. You can sign up to get 4 free tests mailed to your address, so 4 per household. Otherwise, people have to go to the drugstore and buy those. And then another update that I want to provide on the test is the FDA has approved over-the-counter combo tests. So you haven't been able to get access to the flu home test for some time, and that was, again, because of the problems with the sensitivity. But there is now an approved over-the-counter flu COVID home test, which is nice because it can detect both flu and COVID at the same time. But I will, and that was just approved by the FDA at the beginning of October for patients 2 years and older. It's a nasal swab, and it's run similar to the other at-home antigen tests. But it has the same caveat. So that's the important thing to recognize. There's still a higher risk of a false negative assay. It'll be helpful to see clinical data as people are using this to see how it works out. But again, what I would counsel people that use this test is that if they have symptoms and flu and COVID are high and they get a negative test, they need to follow instructions because it will tell them to get another test. Or they may need to be seeing a provider so that they can get a PCR test, a more sensitive test to confirm the diagnosis to see if they need to receive antivirals or not. I saw one of these tests at the drugstore, a commercial-based pharmacy, a community-based pharmacy, a couple weeks ago, and it was $30, and it had 2 tests in it, so it was like $15 a test. So these are not the free ones that you get shipped, but they are available. So summary: diagnostic tests have limitations, but can be helpful. Encourage your patients to have at home not expired tests available with all the instructions. So again, check the expiration dates and older tests. And then patients at high risk for severe disease should follow up if they have negative tests and persistent or significant symptoms. When can I go back to return to normal activities? This is an important question. That guidance changed a lot, as we all know, throughout the pandemic, and it makes sense. We were learning, but it was updated and simplified in March of this year, and they really tried to simplify it for all respiratory virus infections, so we didn't have competing guidelines for flu and COVID. The guidance now states that if you have respiratory virus infection, or if you think you might have it because of symptoms, and those symptoms are listed there, stay home and away from others. And that includes staying away from household members that are not ill. It is possible to prevent household members from getting ill by taking some precautions, not always, but it is possible. You can go back to work or normal activities when you have both of these for at least 24 hours. So overall improvement in symptoms and no longer having fever without using fever-reducing medicines like acetaminophen or NSAIDs like ibuprofen. When you return to work or at normal activities, it's recommended that you take added precaution over the next 5 days because you're still transmissible to others at a lower level, but still possible. And so if you can distance yourself physically, doing good hand hygiene, respiratory hygiene, cleaning your workstation, you can wear masks. That can also help reduce the risk of transmission. And then if you develop recurrent fever or symptoms, you might be having rebound COVID, and you could be transmissible again. So you need to self-isolate and start all over again. So that's the current, most up-to-date recommendations on when you can return to normal activities. So let's talk about vaccines. And first, we need to address the big elephant in the room, which is vaccine hesitancy. This is a long-standing problem since vaccines first were introduced way back in the time of Edward Jenner. Recently, the vaccine hesitancy seems to have increased some over the last several years. There was a nice review article in the New England Journal of Medicine that talked about vaccine hesitancy, and I like their definition, which is a state of indecision and uncertainty about vaccination before a decision is made to act or not act. It represents a time of vulnerability and opportunity. And I think that's an important point to recognize. It's not something that we just give up on, but it really poses an opportunity for us to talk with people about their concerns, to be able to potentially move them closer to acceptance of vaccines, to keep themselves protected. In 2019, the World Health Organization named vaccine hesitancy as one of the top 10 threats to global health because of the increasing rates that they were seeing of hesitancy. And this has grown largely in scope and scale, and it's felt to be largely due to amplification by social media platforms. So this is a nice map of the United States, and this is showing the results of a survey that was done through Facebook, and they asked people about vaccine hesitancy. And then based on their responses, they can develop rates of vaccine hesitancy. And what you can see, the bluer the color, the lower the rate of vaccine hesitancy, the more red the color, the higher the rate of vaccine hesitancy. And what you can see is that throughout the US, even within states, there's variability in different areas with how much vaccine hesitancy is present. So this is helpful for public health to be able to target strategies to improve vaccine uptake, answer questions, remove barriers, but it's also helpful for us to recognize where we're at with our community to see what we need to be doing. Importantly, physicians and other healthcare providers are still trusted for healthcare advice, and that includes advice about the vaccine. So people do have this. There's a Wellcome Global Monitor survey of 140 countries, and 73% of all respondents said they would trust a doctor or nurse more than others. And this was even higher, 90% in higher income countries. So I think people that work in healthcare are respected as trusted, reliable sources of information, which is important in an era where there's a lot of disinformation. So we can increase vaccine acceptance. It's important that we're offering support and encouragement and listening to patient concerns. There are a lot of resources on how to address vaccine hesitancy. This was one that I really liked. It was a really concise document from the American Academy of Family Practice. This specifically looked at COVID-19 vaccine hesitancy, and they provided 8 tips that you can read there. I think you can Google different ones. This one I thought was really nice because it was pretty concise. Really what they are mentioning in this article is the goal is not to see how many people you get vaccinated. I mean, that's the ultimate goal. But the real goal is how many people you can successfully get to think more about considering a vaccine when you're dealing with people that have no desire to take a vaccine at all. So it's really just trying to shift people's thought processes on there with the eventual goal of getting them to getting vaccinated. That's what number 1 is, managing your expectations. They have other steps here, moving through a discussion on how to best talk with somebody about vaccine hesitancy. I think for vaccine discussions, full transparency is important. People can still get respiratory infections, and that's important for them to recognize. Vaccines do blunt severity of illness, so they reduce time that people have to see a doctor, go to the ER, potentially end up in the hospital. Many of the concerns that people have are still the same old questions and myths. Many of those you can find debunked on CDC, so you can look in that as a quick reference for questions that patients may have. A lot of people don't get vaccinated, I believe, just because of the hassle. And so removing some of the barriers there, if you can have vaccine in your clinic or nearby, community-based pharmacies are located close to most people. And then I think an important point for patients is that we're still learning about some of the downstream sequelae of getting repeated infections with COVID-19, influenza. There's some other things that go along with having that infection, even if you get over it, never have to see a doctor. There are reasons to get vaccinated to try and protect yourself from repeated infections. So let's talk about the vaccines themselves. In August 2024, the FDA approved and authorized updated or new COVID vaccines. And Moderna and Pfizer both contain KP.2. Novavax contains JN.1. The leading variant now is KP.3.1.1. And that's important because it better matches with what's circulating now. The prior vaccine, just for context, contained XBB.1.5. And what we've learned is that it's important that we update the COVID vaccines. So this is a really busy slide, but it's looking at the different variants. The red box puts what the lead variant is right now. And those red arrows are showing what the Novavax, Moderna, and Pfizer vaccines contain in them. So they're more closely matched. The XBB.1.5 is way down lower here. So if people haven't been vaccinated since last year, they're not going to have vaccine protection for the most up-to-date strains that are circulating now. They won't have as good protection. ACIP, which is part of the CDC, has really moved to simplify the vaccine recommendations for COVID-19 because of obvious COVID fatigue that everybody's had. Really, for most people, it's just going to be one dose, regardless of prior doses. You do need to look at the schedule for children that are 6 months to 4 years of age. But for most people, it's going to be one dose. And they want people to get the most up-to-date vaccine so they have the best protection. Now, they did update the recommendations October 31st for vulnerable patient populations. So those are our patients that are 65 years and older, or people that are 6 months and older that are moderate to severely immunocompromised. And for those patients, they do recommend that they get a second dose six months after their first dose to really boost up their response, because there is waning of that immune response after you get the vaccine, particularly in vulnerable patients. So how did the COVID vaccine do last year? This is a busy slide, but on the left side, I don't really like this data because they showed vaccine effectiveness, but they included people that didn't not only had the most up-to-date, but also people that had prior year's vaccines versus no vaccine. And so what you see is that reduced the vaccine effectiveness for preventing hospitalizations was only about 44%. From having to see a doctor is about 43%, so low 40s. On the right-hand side, what you see is the updated look for people that had the most up-to-date vaccine versus no vaccine. And you see that the vaccine effectiveness is better. So it was 58% for the XBB variant if they were infected with that, because that's what the vaccine contained. And then when you looked at critical illness, you had pretty good vaccine effectiveness, almost 70% up to 2 months. But when you started getting out to 6 months, it dropped to 32%. And so this is the reason why they're recommending getting an updated vaccine each year. And then also for vulnerable patients, getting a repeat booster 6 months later so that they have continued protection. So I want to talk about RSV. This was 2023, last year was a big year because we had finally some RSV prevention measures. RSV is the leading cause of hospitalization amongst U.S. infants. There was estimated 58 to 80,000 hospitalizations of children less than 5 years of age. So really a lot of children get hospitalized. And it's also increasingly recognized as a cause of severe respiratory illness and cause of hospitalization in our adults that are 65 years and older. You can see the numbers there, 60 to 160,000. But we now have recommendations to protect both of these vulnerable groups, which is great. For infants, there are two different strategies. So one is to give a one-time dose of the Pfizer RSV vaccine for pregnant women at 32 to 36 weeks gestation. If they're at that time period between September through January, and this was safely tolerated. And what that allows is for passive immunity, passive transfer of antibodies from the mother to the infant. So when the infant is born, they will have circulating antibodies against RSV, which is really important because infants don't start to generate antibodies for the first 6 months of life. The other strategy is to use a long-acting monoclonal antibody called nirsevimab. So if the mother did not get that vaccine during that time period, you can administer nirsevimab for infants that are born or entering their first RSV season. So that's another strategy that can be used. For our older adults, right now it's just recommended that they just need a single dose, a one-time dose of any FDA-approved RSV vaccine. So all adults 75 and older, and then adults that are 60 years and older that have a risk factor for severe RSV disease. And I'll show you the slide with those risk factors. At this point, it's not recommended that they have to get another dose. So for those adults that got it last year, they don't have to get a repeat this year, because it looks like they still have protection for at least 2 RSV seasons, which is fantastic. And here you can see a gentleman that's very happily getting his RSV vaccine, and someone that's happily administering as well. Hopefully everybody's that happy as they're getting their vaccines. So here are the risk factors for severe RSV in adults that are 60 to 74 years of age. Again, this looks very similar to the list of risk factors for severe COVID-19, severe influenza. If you have chronic medical conditions, diabetes with complications, severe obesity, immunocompromised, nursing home resident, and then they list other chronic medical conditions or risk factors. So very similar list. So how did the RSV vaccine do? So this is the update from CDC. Actually, it's published in Lancet, excuse me, that showed RSV vaccine effectiveness. It actually is very effective for both vaccines and for all age groups. So for the adults 60 years and older, not immunocompromised, it was 80% effective in preventing RSV hospitalizations, which is fantastic. Also 81% effective in preventing critical illness, which is defined as ICU, death, or both, and 77% effective against ER visits. So it did really well. And it only dropped a little bit for immunocompromised adults 60 years and older, so 73% versus 80%. So the RSV vaccine appears to be really effective. I think the big key here is to get more people vaccinated. Updates in flu vaccine recommendations. We've been getting flu vaccines annually for quite some time. Really, the biggest change is that they moved from a quadrivalent to a trivalent vaccine because one of the B strains that used to be included has not been seen since the pandemic, since March of 2020. So there's only 3 strains in the vaccine at this point. Otherwise, most people that are 6 months and older just need to get 1 dose. If they're 65 years and older, then they're supposed to get a kind of a souped up vaccine so they have a more robust immune response. So either high dose, recombinant, or adjuvanted, but everybody should get 1 dose. And ideally, you're offering it September, October, really in advance of flu activity picking up, which we're starting to see now, but it's not too late to get it now. So here's a kind of a bar graph showing seasonal flu vaccines over the years from 2005. And you can see there's variability. I want to say, just mention briefly, how does this get monitored? So the CDC works with these outpatient settings in their influenza vaccine effectiveness network, and they enroll patients that have influenza-like illness, and they test them with PCR to see if they have flu, and they use that to determine what the vaccine effectiveness is. And I think that's an important metric because it helps us better understand how are we doing with giving people flu vaccine? Do we need to adjust flu vaccines? But I don't think for patients that are trying to interpret what's going on, it's the best metric or tells the full story of the benefits of flu vaccine. We have a lot of published data that shows that flu data reduces hospitalizations, decreases the risk of ICU admission in children and adults that are already hospitalized, and it reduces symptom severity amongst patients who get flu despite being vaccinated. So there are other benefits that I think we need to let people know about to really promote better uptake with flu vaccine. We're having problems with vaccine uptake, as I mentioned at the very beginning, of vaccine hesitancy. This is just published October, so October this year from the CDC and the MMWR, and it was looking at healthcare personnel uptake with vaccines. We know that healthcare personnel are going to be exposed based on the nature of their work. So on the top, you see flu vaccine coverage, acute care hospitals on the left, and nursing homes on the right, healthcare personnel that work in those areas. On the bottom, you see COVID-19 vaccine coverage, which is even lower in acute care hospitals and nursing homes. So you can see at acute care hospitals, about 80%, SNFs, about 45%. COVID vaccine dropped significantly down to 15% and 10.5%. So unfortunately, we have a lot of room for improvement for how our healthcare personnel are doing. And if it's that way in healthcare personnel, you can recognize that it's even more of an issue and people that aren't in healthcare, that aren't regularly exposed, that don't think that they're at risk, even though they are. So combined respiratory vaccines are coming soon. Hopefully, Pfizer and Moderna both have phase 3 trials with combined COVID flu vaccines, and we anticipate those are going to be available in 2025 if the data is positive. Moderna is reporting positive results, so that's encouraging. Novavax also is launching a phase 3 trial with hope of a 2026 fall availability. And then just to mention, they're looking at other respiratory viruses as well. AstraZeneca has this combo RSV human metapneumovirus vaccine that they're looking at. More to come on that. But the combo vaccines should help some with convenience. So to summarize with vaccines, there are significant challenges with vaccine hesitancy since the COVID-19 pandemic, especially with the COVID-19 vaccine. But vaccines remain the most effective method of preventing severe illness with respiratory virus infections. So we need to be having transparent discussions with patients, clients, family members, community members with questions, and encourage all patients to be vaccinated. From a public health perspective, I think we need better messaging about the benefits of vaccines so we can do a little bit better at promoting the reasons why we know that people need to get vaccinated. There's good data that proves why it's important. So last, I want to just talk briefly about antivirals because I think these are also important tools. We know that people still can get sick with respiratory virus infections, even if they've been vaccinated. Now, their severity might be less if they're vaccinated, but it's important to know that antivirals are there as well. So we're using kind of a belts and suspenders approach to respiratory virus infections, particularly for flu and COVID, where the antivirals are available. So here is an overview of our outpatient treatment options. For influenza, we have oseltamivir and baloxavir, which I think a lot of people are not familiar with. I'll briefly mention. COVID-19, the biggest outpatient treatment option is trade name Paxlovid. It's nirmatrelvir, ritonavir. Remdesivir is IV only, and so that's not really used outpatient that often. And molnupiravir, CDC really recommends only using if it can't use other meds. I would really recommend trying to use Paxlovid. RSV, we do not have great treatment options. It's supportive care. So I just want to show this. This is older data, but it shows that we've had influenza antivirals for a long time, and we do not do a good job as a healthcare community in using them. So this was studies that were participating with the CDC in flu vaccine effectiveness. So they know that they're working with the CDC in a research format. And what this bar graph shows is how many outpatients received antiviral therapy. And this is, so it's 15% with PCR confirmed influenza received antivirals. That's way too low. When they looked at patients that were at high risk for flu complications, they had a little over 1,000 of those patients that presented within 48 hours from symptom onset. So really optimal time to use that influenza antiviral. Only 19% of them were prescribed an antiviral. However, 30% received an antibacterial agent, and that's going to do nothing for influenza. So it shows that we really have a long way to go. We really need to improve use of influenza antivirals. Now, a lot of people, I think, are anchored to the initial trial data with influenza antivirals, where they think they don't do much other than shorten symptom duration for 24 hours. And that's probably true in a normal, healthy, immunocompetent person. But in people that are at high risk for complications, there's actually pretty good evidence it can provide more benefit, can keep people out of the hospital. This was a study that came out in 2020 in Lancet, right when COVID was happening, and people were not paying attention to the flu. But I like this study. It was open label. It was 15 European countries over 3 flu seasons. They enrolled 3,266 patients. And those patients with flu either received oseltamivir, or trade name Tamiflu, or they just got supportive care. They didn't get an antiviral. And they enrolled patients up to 72 hours from symptom onset. And what they saw was that overall, there was about a 24-hour reduction, 1-day reduction in symptoms. But when they looked at the highest risk patients, patients that were 65 and older or had medical comorbidities, they saw that they reduced symptom duration by 3 days. So there really was an impact there. There's also been some studies showing decreased hospitalization, and then patients that get admitted to the hospital, decreased risk of going to the ICU. So there are benefits for influenza antivirals in our patients that are at highest risk for complications. I want to briefly mention baloxavir because I think a lot of people are still learning about this medicine. So this schematic shows an influenza virus life cycle as it moves through the host cell from entry all the way to budding and release. And the neuraminidase inhibitors work in that far end at the budding and release of new virions. Baloxavir works kind of further upstream. It blocks mRNA transcription. And so it's helpful that it has a novel mechanism of action because it allows it to still work in a flu virus that's resistant to neuraminidase inhibitors or Tamiflu. So just briefly, baloxavir was compared in a study that compared it to oseltamivir and placebo. And what they saw was that it was statistically significantly better than placebo, but really about comparable to oseltamivir. So it works well. It's another option. I just want to mention that so people are aware of that. One difference between baloxavir and oseltamivir, as you know, is you take twice a day for 5 days. Baloxavir is a 1 dose for the entire course drug, which is an interesting thing. And it can be helpful for younger patients that don't like to take pills or people that are non-compliant. So this is a quick overview of the Paxlovid study, the EPIC-HR trial, where they looked at oral Paxlovid for high-risk outpatient adults that had COVID-19. It was a double-blind randomized controlled trial. They randomized a little over 2,200 patients, and patients either received placebo or Paxlovid, and they looked at how many patients were hospitalized or died within 28 days. And they saw that, you can see on the graph there was an 89% lower risk of severe COVID-19 progression in patients that received Paxlovid than placebo. So really significantly impactful on these patients. All 13 of the deaths that occurred in the study occurred in the placebo group, 0 deaths in the Paxlovid arm. So really we should be using Paxlovid more often. Unfortunately, this was a health study in the Health Affairs that came out as a survey this year, it was published this year, and they were asking people about their awareness of Paxlovid. And you can see by the title, the majority of Americans had no or low awareness of Paxlovid for treatment of COVID-19. And it was really a little unclear. There's certainly been a lot of marketing about that. But looking at the US adult population, fewer than 25% of eligible adults have received Paxlovid, even though many of them would benefit from it. 85% of people that were in that survey of 1,400 adults had low or no awareness of Paxlovid. And of those who had heard of it, they had misperceptions. They thought there were a lot of adverse effects, which was looked at in that study I showed, and it was well tolerated. The lower awareness and misperceptions were actually more common amongst people that are more medically vulnerable and disadvantaged, which is a real problem. So I think it shows that we need to be doing better with antivirals for respiratory virus infections. So we should be vigilant for high-risk patients, educate our high-risk patients about the availability and importance of antiviral therapy. Certainly they should get vaccines, but they should know about antivirals as well. They should seek care early. The earlier you start these antivirals, the more you optimize their benefits. The treatment is generally well tolerated for all three of the drugs that I mentioned, and data supports it as effective in preventing progression to severe disease. So to conclude, I wanted to just say that I think it's really important during respiratory virus season to keep up to date on what's circulating. So you know what's going around, you can help inform and educate. You can sign up for flu alerts, these CDC Health Advisory Network alerts. You should inform patients, clients, family members, community members, especially high risk, on how they can prepare. So vaccines remain our best tool to prevent severe infection. People can wear well-fitted masks with increased respiratory virus activity, particularly if they're going to crowded indoor settings. And there's a lot of that during the holiday season. Keep your residence stocked with appropriate gear. So a thermometer, pulse ox, masks, hand sanitizer, antipyretics, home tests can all be helpful to have at home. Get the vaccines for which they are eligible, and then be aware that their early antivirals for COVID-19 and influenza can be effective in reducing severity of illness. And that's all I have. I'm happy to take questions.
Thank you. Thank you, Dr. Bowling. This has been comprehensive and detailed, a very good presentation. We appreciate it. Thank you, Dr. Bowling. We can move to some questions. We have a couple of questions in our chat. First, we have, what are the expected reactions following vaccinations for COVID?
Sure. Yeah, that's a really important question. And a leading concern that people have about getting the vaccine, right, is the side effects. The good news, so what I like to tell people is that at this point, actually, COVID vaccine is one of the most studied, if not the most studied vaccine in history. And there is ongoing safety monitoring with it as well. So they continue to monitor safety events with the vaccine for as long as it's available. The most common side effects when people have them are local side effects, right? Soreness, redness, and swelling of the arm. That's pretty common, can last for a day or so, and then goes away. Serious side effects, when they've looked at this huge registry, are actually very, very rare. Other people can have additional side effects, so the local side effects are there. Some people may also have some low-grade body aches. They can feel fatigued, and that lasts for up to 24 hours, usually starts to go away around that time period. So some people can have some systemic side effects as well. So there's some variability. At one point, people were looking into whether or not that reflected that you had a more robust immune response if you had more side effects. Did that mean you're generating more antibodies? It's not clear that that's the case, but if people feel better about it because that's what they gets them motivated to get it, I don't know that it's not the case, but there's just not information on that. But those are the most common side effects that people have.
Thank you. We have another question here. Someone says, a common question that I hear is that, is the at-home test still good after expiration date?
Yes, excellent question. So what I would recommend doing is if you type into your internet browser of choice and you type FDA COVID at-home test expiration date, it'll take you to that web page that I showed. And they have a list of the available COVID tests. You can scroll down to the one that matches your box. So have your box of COVID tests so you can look at that. And then the lot number is on the box as well. Once you get to that box and match it, you can click on it and you can type in the lot number for your test. And it will tell you if the FDA's extended the expiration date and if it did, what that extended expiration date is. If you're past both those dates, you shouldn't use the test because it's not going to give you good, reliable information. I mean, if you use it, realize that you could have a negative test that might not mean anything. And that's unfortunately what I did before. So I can say from personal experience, even though that I deal with this all the time, I used an expired test for myself. Then I got a good test. But so there's a follow-up on that story. I didn't just stop there. I didn't realize it.
Thank you, Dr. Bowling. I also wanted to ask, I've heard many people expressing this concern. Persons who are allergic to certain substances, but persons who are sensitive to allergies in general, how safe is it for them to use vaccines, specifically COVID?
So most of those will not impact it. So the allergies of real concern are allergies to other potential ingredients in the vaccine. There's not many in there, and you can go to the CDC webpage. They actually list those ingredients. If you really have concerns with that, you can talk with your doctor to see if you've had a reaction before. I think an important thing to mention that had been a historical issue for some time was concern of having egg allergy and receiving the flu vaccine. And now at this point, fortunately, we have data that shows that that's not an issue. Egg allergies tend to go away over time, and people don't have significant reactions. They've actually tested people that had egg allergies with the flu vaccine. So the reactions that you can have with allergies to COVID vaccine, there's just a few ingredients. So it is possible that you could have, it's pretty rare, but it is possible for people to have a reaction to an ingredient in that vaccine. A primary care doctor would probably need to refer you to an immunologist if that was really something to look into further to see which you could safely get.
Thank you. I see another question here. Someone asks, does mask wearing really make a difference when infected with COVID-19 and with the flu?
Yes, so you could still, it's a good question. If you have a well-fitted mask, there's different ways to look at mask wearing, right? So there's masking where both people are wearing masks, and if both people are wearing masks, that's the best protection. But I would basically say it's a spectrum of protection, right? So if both people are wearing a mask, you're the most protected because there's still some potential issue if someone coughs or sneezes that you might get some escape of particles through a mask, right? They're really rated more for what comes in. However, one-way mask wearing is still better than not wearing a mask at all. And one-way mask wearing, which means just you as the individual wearing a mask and other people are not wearing a mask, can also protect you from other people that might be sick around you. So it's not 100% protection, but you should really think of all of these as layers of protection, right? So you get the vaccine, that's not 100%, but it can help reduce your risk of infection and reduce the severity of infection. A mask, that's not 100%, but it can also bring another layer, and it also protects against infection as well. I'll mention that before we had vaccines, and we were seeing COVID-19 patients, and we were having shortages in N95. I saw many COVID-19 patients wearing just a respiratory mask, just a well-fitted surgical barrier mask. And so there is protection with wearing those, but it's not 100%. That's important to recognize as well.
Thank you. Someone here in the comments says, what about those who say that when they wear a mask, they feel like they're short of breath?
Yeah, you could certainly, some of the masks are more uncomfortable than others. The N95 respirators certainly are more confining. That's why they block more coming in, right? That's kind of their job. But some people can feel a little more short of breath and have difficulty with it. Some of that is acclimation. Some of it depends on what activity you're doing. From a safety standpoint, it's safe to wear, but some people do find that uncomfortable. That's where I think if you use like a well-fitted barrier mask or surgical mask, medical grade surgical mask, those allow a lot more air in, or less confining, and people tend to be able to wear those for longer periods of time without as much issue. Now, if you switch straight to like a bandana or some of these gaiters, those are the ones that they're the most comfortable, but that's also because they're not really blocking much. So those are the ones I would be careful and caution, say those probably are not providing much of a layer of protection.
Thank you. And one last question we have here, someone saying the data suggests a connection between substance use disorders and severe outcomes in respiratory illnesses. So how can healthcare systems integrate substance use treatment with preventive care for respiratory infections? That's a big one.
Yeah, that's a fantastic question. So I think what we need to have more of a recognition that substance use itself is something that should trigger our mind that we need to be thinking about respiratory virus infection. Usually we think of that and then we start looking at their other health problems, right? Well, do they have diabetes? Do they have severe obesity, right? But I think we should start looking at just substance use disorder because it might be a proxy that there's other issues that put them at higher risk. Some of which we could find out later, some of which we may not because we don't have a lot of ongoing contact or relationship with this patient or client, right? And so I think that would be a reason, a way that we might need to shift our thinking a little bit. When we see substance use disorder, also think of what we need to be doing to promote their health, not only related to their substance use disorder itself, but for things like this, preventative measures, right? We probably need to give them information about vaccines, see if they need help with accessing where a community might be providing free vaccines. They tend to have those pop-up events, things like that. So I think we could do a better job of aligning some of our education on preventative measures, especially during respiratory virus season, so we can keep them better protected.
Thank you. And just to remind our participants, all the wonderful material presented by Dr. Bowling today will be shared with all of you after the session, along with the post-survey session. So you will have access to this didactic material for sure. In the meantime, I think we're going to be moving to announcements very quickly. But if anyone in the among the participants has any other questions, please feel free to send them to us via email here at CSTAT, and we'll be more than happy to answer your questions or to provide you with any resources related to today's topics. So let's go to the announcements, and whenever we are ready.
Do I need to stop sharing my screen?
Uh, yes, I think we need to share. Um, okay, there you go. Here we have it. All right, so just wanted to remind all of you that the Center for Substance Use Training and Telementoring CSTAT offers technical assistance. If you're interested in substance use disorder technical assistance, please go to our website. That is cstat.utesca.edu. There is a form there, and someone will contact you in approximately 2 or 3 days after that. Next. Next slide. And to claim your seat today, remember, if you're looking for CMEs, just make sure that you send the code attend 100-980-99 to the phone number that you see on the screen. If you are looking for your certificates, please be on the lookout for our post-session survey after this class. We're also sharing it with you on the chat right now. When you answer the post-session survey and you express that you want a certificate, please give us approximately 3 or 4 weeks for us to generate and send you the certificate via email. It's very easy. Next. And that time of the year is here again. The 2025 Texas Substance Use Symposium is open for registrations again. If you want more information, go to our website. That is texas.org, txsus.org. Next slide. And if you or someone you know is interested in sponsoring our symposium, same thing, just go to our website and we'll give you options. We are looking for persons who wants to be sponsors or who want to be exhibitors. And there is a variety of sponsorship and exhibitor packages for everyone. So please go to our website. Remember, this symposium is going to take place in El Paso, Texas this year on February 27 and 28. Next slide. And next month, on Friday, January the 10th, we'll have Dr. Weems talking about ensuring continuity on behavioral health services during COVID-19 incidents. That's Friday, January the 10th. So be on the lookout for more information about this session. And once again, I want to thank you, Dr. Bowling, for an amazing presentation. This was really informative, comprehensive. Very, very happy that you had the opportunity to share this information with us. Again, we'll share the material with our participants after the class. Thank you to all of you, and we'll see you next month. This has been great. Have a wonderful rest of your day. Thanks.